Hi, all. I'm going to give it just a minute, let people get connected to sound and all the good things. We are so excited to have you here. My name is Kayla Fulginetti. I'm the Senior Director of Elephants and Tea, and you are at session 7 of AYA Power. If this is your first session, welcome. We are so excited to have you here. If you are a repeat powerer, welcome back. This entire program is dedicated to providing oncology trainees with education and resources to make sure that we are really looking at ways to improve care delivery for adolescents and young adults with cancer. If you are unaware, we do these monthly sessions live through Zoom, but we also record every single session. It is all available on demand on our website through Elephants and Tea, and I will drop that in the chat. So if you miss a session or if you're looking for a specific topic, please check out the website. We have 2 seasons already there. We are actually wrapping up season 2 next month, which seems crazy that it is already wrapping. But I am here just to provide a couple of housekeeping and some updates. First of all, we want to thank our sponsors for Power, the I'm Not Done Yet Foundation and AZI, who have been supporting the program and really helping us getting this up and running. This is a webinar, so we won't be able to see your wonderful faces, but please, we love questions to our experts, and the Q&A at the end of the didactic is really the opportunity to ask the questions. So you will see down at the bottom of your screen, there's the little Q&A button, so please make sure that you are dropping questions in there for our speaker. I already let you all know about our recording and the on-demand database that is available there, and I will share about our last session at the end. So I think kind of without further ado, I will introduce our amazing speaker for our session today. He is an individual who loves to be talked about, and so I will drag on his bio for a very long time and simply say that he is an amazing physician advocate for young adults and human all around. Dr. Mike Roth is a professor of pediatrics at MD Anderson, where he's the co-director of the Adolescent and Young Adult Program and director of the Childhood Cancer Survivorship Program. And that's all I will say. So I will give it to you to take it away. Thanks, Mike.
Thank you, Kayla. I must admit I get nervous with you presenting or kind of letting folks know that I'm coming to join and present. I had no idea what you would say, and that was very kind of you. Also, we'll thank folks for coming back. You could see the date on the title slide was last week, which was the same time where we had a Zoom outage, and I wasn't sure if the world was ending because I didn't know how we exist without Zoom functioning, but I guess you just postpone things and Zoom eventually comes back and we meet a week later. So thanks to those who were able to arrange their schedules. For others, this will be recorded and we'll share it with the rest of the team. This is going to be a brief update on AYA cancer clinical trials, where we are today, what are some current challenges, meant to be brief, and hope there will be some good questions and discussion at the end. I do not have any relevant disclosures other than I care deeply about increasing access to AYA trials for all patients. So this is my favorite figure of all time. Why are clinical trials important? Of course, looking back at ALL and children diagnosed with ALL over the past 7 decades now, we see that trials work and trials lead to improvement in outcomes for many diagnoses. And this is the model. This is what we hope to achieve in all cancer diagnoses. And this is probably the best figure in terms of advocating for the utility of cancer clinical trials in general. So what are the challenges for AYAs? I see Dr. Blyer on the call here, and I'm always nervous about presenting other people's data. And I haven't changed this slide in years because it dramatically shows the valley in AYA enrollments onto cancer clinical trials. As you get into the late teens, early to mid 20s, we see few AYAs enroll onto cancer clinical trials. If we were to overlay certain populations, such as Black AYA males in their 20s, we would see minimal participation onto cancer clinical trials. Some might look at the figure on the top right and say, well, AYAs enroll at a similar proportion compared to older adults. That may be true. However, the denominator is very, very different. Over 300,000 women are diagnosed with breast cancer each year. Only about 85,000 AYAs total, all cancer diagnoses, are diagnosed with cancer each year, which means we have to enroll a higher proportion of our AYAs similar to younger children and their high participation rates. If AYAs do not enroll onto cancer clinical trials, we do not have biospecimens, we cannot identify new targets, and we cannot make the progress that we need to make at the rate that we're hoping to make progress for this population. So when we think about what's required to have a successful enrollment of any patient onto a cancer clinical trial, I always go back to the framework by David Fryer and Nita Seibel. And essentially, it's every step in the process to have a patient participate on a study. Initially, a patient has to be diagnosed with cancer. They need to have a diagnosis where a clinical trial exists nationally or locally. They need to present to a location that actually has the trial available and that trial is accessible for that specific patient. The provider needs to think about that patient and be aware that the trial is open locally and then present that trial to the patient. And then the patient has to accept that trial. And if any of these steps go wrong, essentially you do not have a trial enrollment. So for years, there's been a lot of anecdotal comments about what the barriers are to AYA enrollment and why few AYAs were participating on studies. We have strongly believed that there are many barriers at all levels, including community, societal, provider level, and patient level. And when we actually did a systematic review looking at the evidence, we found very few articles actually provided real-world data on what those barriers are. So for us, it's really important to make sure that we were identifying the barriers to AYA enrollment and addressing those barriers to make sure that we are overcoming those challenges and increasing enrollment. We've done several studies using quantitative as well as qualitative data going into both academic sites as well as community and under-resourced sites to try to understand at the system level, institutional level, and the provider level, what are the barriers to AYAs enrolling on trials? And I think the biggest barrier that we see across all sites is prioritization of trials or lack of prioritization of AYA trials, and the acknowledgement that financially it makes more sense to open a study for older adults with breast cancer or prostate cancer because you will get many more enrollments in a shorter period of time than opening an AYA study, acknowledging that all AYA cancer diagnoses are rare cancers. So getting past that willingness to open AYA studies locally is a huge issue. And then beyond that, we start to get to challenges between pediatric and medical oncologists regarding silos that naturally occur within our institutions, some of the logistical challenges regarding IRBs, whether they are shared IRBs across medical and pediatric oncology, and also the resources that are needed to actually support the regulatory components of opening and maintaining these studies at our institutions. Now, hearing all of those barriers, I will tell you it is not all doom and gloom. We are making a lot of progress, which I'm going to share in the next few slides, but it's important to understand what are we up against? Why historically have we not had more vigorous enrollment? And what do we need to do to make sure that there are more trials available at the national level, opened at the local level, and actually accessible to our patients? So let's talk about how we've worked to improve AYA outcomes through these AYA trials. So long before the NCI reorganized in 2014, there were folks like Dr. Blyer and many others who identified the gaps in AYA outcomes and AYA care. And it's only over the last decade or so where we've been able to develop true AYA cancer clinical trials that bridge the gaps between pediatric and medical oncology. And back a decade ago, when the NCI reorganized, essentially what it did is it brought the Children's Oncology Group, the Pediatric Cancer Clinical Trials Group, closer together to the consolidated adult network groups. And essentially, COG and the adult groups were nudged to work together to develop trials that span the AYA age range. To be clear, AYA trials were not the impetus for this reorganization, but clearly it's benefited from the reorganization. So how has this process worked? Well, I'll say there's been a lot of challenges, and there's been a lot of challenges long before I had a leadership role within these groups. Specifically, what were those challenges? Well, anytime you're going to introduce a new framework and bring people together who historically have not worked together to develop shared clinical trials, there's a steep learning curve. And we learned a lot of this through the first AYA collaborative trial, ARST 1321, which was a soft tissue study, which was fully available across the network groups, COG, SWOG, ECOG-ACRIN Alliance, NRG, and we learned that working together at the earliest stages, developing the concept together, is the best way to optimize your study enrollment and interest in actually having their patients participate in these studies. Over the past decades, groups such as the Hodgkin lymphoma committees, as well as the germ cell committees, they have committed and dedicated their groups to developing new studies fully collaboratively. They will only develop new studies together between medical and pediatric oncology. And that really is a game changer, as you'll hear with a few case studies coming up. So let's talk a little bit about the AYA therapeutic trial portfolio that has evolved and developed over the past decade. So this is the current NCTN AYA cancer clinical trial portfolio. And what you can see here is that there are AYA trials available across a number of common AYA cancer diagnoses. You have sarcomas, lymphomas, leukemia, germ cell tumors, and these studies are both for newly diagnosed patients, and then there are some studies for those with relapsed refractory disease as well. I have starred here those studies that are led by COG, by the Children's Oncology Group, with participation from the adult network groups. Those that are not starred are led by the adult groups, and the Children's Oncology Group participates in those studies as well. If we dive deeper into a couple recent trials that have been true successes, the immediate one that comes to mind is the S1826 study, which is for patients with newly diagnosed advanced Hodgkin lymphoma. So I'm going to summarize a ton of work and collaboration led by Kara Kelly, led by colleagues on the adult side. This is a collaborative study that was led by SWOG with true collaboration with the Children's Oncology Group. And Alex Herrera was the PI in SWOG and has been a wonderful partner in developing these Hodgkin trials together. And what's really exciting about this study for the AYA population is it investigated two novel agents, nivolumab as well as brentuximab, in the same study, and essentially was able to bring immunotherapy to the AYA population in the context of this trial probably a decade earlier than we would have been able to do had we not been able to participate in this collaborative study. So the concept is nivolumab plus an AVD backbone versus brentuximab with an AVD backbone. And it took a lot of work to harmonize the approach, knowing that the backbones were different historically between pediatric and adult medical oncologists in terms of what they use for patients with Hodgkin lymphoma. Their use of radiation differed as well. But the success of working together is highlighted by the fact that the trial closed a year early due to rapid accrual. And this was even during the pandemic. The Children's Oncology Group participated in this adult-led study and contributed 50% of all AYAs on the study, and new novel agents were able and were accessible to AYAs and the sort of younger adolescents at a much earlier stage than expected. When we look at the results, this was published in the New England Journal last year. You can clearly see that both the Nivo AVD arm as well as the brentuximab AVD arm had really high levels of progression-free survival, with the Nivo arm being superior. And what is really exciting and important in a disease where there's such high survival and cure rates is that late effects will likely be minimized because very few patients on either arm were exposed to radiation therapy. Thus, we will see in 10, 15, 20 years, likely a much lower rate of cardiotoxicity subsequent secondary breast cancers. Now, we do not know many of the late effects associated with immunotherapy, but this is what progress looks like, working together to identify the new standard of care and then move on to the next study to further improve outcomes. The next study I want to highlight is in patients with primary mediastinal B-cell lymphoma. And this is a really important study because it's a very rare cancer that we would not be able to lead a study in this disease unless we had an AYA collaborative study. So fewer than 100 patients diagnosed under the age of 21 each year, about 400 diagnosed across the country each year. Patients often present very sick with a large mediastinal mass, pericardial effusion, often go to the intensive care unit. The biology is actually similar to Hodgkin lymphoma, and there's been many questions as to what is the optimal treatment approach for these patients. So without getting too much into the details, this was essentially a study looking at the addition of nivolumab to a chemotherapy backbone. And I'm being vague about what that chemotherapy backbone was because in this scenario, in this disease, it was allowed to be dealer's choice. Providers could either give R-CHOP or dose-adjusted R-EPOCH, whichever they were used to giving and more comfortable giving. And then there was also flexibility in terms of who would receive radiation. The reason why there was flexibility in the backbone and the radiation guidelines was because this is a difficult study to accrue on in a short period of time, given how rare the disease is, provided cancer incidences in the AYA population. And even though this isn't the perfect study, it's the best study and the most feasible study we could do given these limitations. Study was opened in June of 2021, anticipated to enroll 186 patients over about 4 years. And this is one of my favorite figures in the slide set. The red dotted line is the projected accrual, that black line is the actual accrual, and this study is on the cusp of closing to accrual, even with an expansion of the cohort. And the reason this was expanded is because the stats, we realized, and this is led by Lisa Roth, they realized that the stats could be even more rigorous because we were having rapid accrual. So the cohort was expanded to 236 evaluable patients, and that is almost completed. You can see in the figures on the bottom right that there is participation by all of the network groups. You can see the age range over 170 patients are over the age of 18, with about 60 under the age of 18, which means that these patients are truly representing the AYA population. So what have we learned from these two studies? We've learned that these studies need to be developed and designed together at the earliest concept phase between medical and pediatric oncology. There needs to be flexibility between both groups, and the studies need to be feasible. What are the advantages of developing AYA trials? Early access to novel agents, shorter enrollment time, identification of new standards of care sooner, ability to evaluate more agents in a shorter period of time, and the opportunity to address clinical questions when we would not be able to do this had we just focused on enrolling only patients younger than 18 or 21 or only patients over the age of 21. So what have the AYA cancer clinical trials that are cross-network, what does this look like across the NCTN over the past decade? I do not need to update folks on this call that we're in challenging financial times and there's a lot of uncertainty regarding NCI funding and NIH funding. And I think when you look at the figures here, what you can see is clearly over the past decade, there's been a decrease in the total number of treatment trials and enrollments over the past decade. And that's what you're seeing the figure on the left. There was a peak of patient enrollments around the year sort of 2009, 2013 or so. And in subsequent years, the number of studies funded has decreased overall. However, if you look at the figure on the right, what you're seeing is that a higher proportion of all patients enrolled are AYAs. And that what that means is that the process is working. The development of co-led and co-developed studies is contributing to a higher proportion of all patients enrolled who are AYAs. Ideally, both of these curves would be higher, meaning we would have more funding for more AYA trials, and the proportion of patients on all studies would be AYAs. But I do think this process is definitely more than proof of concept that AYA trials work, and we can do this, and we can overcome the barriers to AYA enrollment. So let's move briefly to talking about supportive care, late effects, and cancer care delivery studies for AYAs. This is the next wave of studies that are coming. This is the current COG-led supportive care and care delivery and survivorship study portfolio. The first study is a COVID vaccine response study, which is recently closed. The next two studies I'm going to present, looking at liver toxicity prevention in ALL and ovarian protection for patients receiving agents that can be toxic to the ovaries and cause infertility. And then on the right side, we can see a study that looks at an exercise intervention for survivors of younger AYA cancer. And finally, the cancer care delivery portfolio, which is on the cusp of really booming with multiple studies, hopefully soon to launch. So let's mention two brief supportive care studies and survivorship studies. The first is ACCL 1931. This is led by Eitan Orgel, and it's looking at levulcarnitine prophylaxis to prevent asparaginase-induced liver toxicity in AYAs with ALL. Very briefly, we know asparaginase is an important drug for AYAs with ALL. AYAs who are obese are at a higher risk for developing liver toxicity. And if you do not get a significant amount of asparaginase during treatment, those AYAs have significantly poorer survival outcomes. So this is a pretty kind of basic study design. This is an induction for AYAs newly diagnosed with ALL, and patients are randomized to either receive levulcarnitine starting before receiving asparaginase, or they're randomized to no prophylaxis with the opportunity to cross over for those patients experiencing liver toxicity. There's short study endpoints looking at liver toxicity measured by hyperbilirubinemia. And of course, there's other outcomes as well that we're looking at. This is my second favorite figure in the slide set. What you can see is clearly in blue for the first year, a year and a half or so, we were well above the expected accrual. The study had to shut down temporarily for just a few months due to drug supply. And once the study reopened, it picked up right where it left off. And we can see clearly that there are patients above and below age 21 who are being enrolled on this study, with a third of patients having obesity, which puts them at a higher risk for developing toxicity. This study is working. This is proof of concept that we can lead AYA studies within this population focused on supportive care. The final study I'm going to present is ALTE 2131. This is led by Eric Chow and Jen Levine, and this is focused on a GnRH agonist seeking to protect ovarian reserved in AYAs receiving gonadotoxic therapy. That is recently launched and just started accruing. For those of you who are at sites who do not have this open yet, please strongly consider doing so. Very importantly, I want to note that our studies are only as impactful to the point and extent to which they are implemented in the real world cancer setting. So we know there are many gaps in care delivery for AYAs treated at both academic and community settings. You can see some of the domains where we have very large gaps in care delivery. We need to do this better in a pragmatic way and not just identify new standards of care and what the guidelines are, but make sure that these guidelines are implemented. Currently, we know that rates of fertility education and preservation are exceedingly low. Screening for financial toxicity, emotional distress, and actually addressing those needs are rarely met. And we're not doing an adequate job meeting the needs of AYAs. And that's where cancer care delivery research comes into play. And that's where we're moving next, in addition to the supportive care and survivorship AYA studies. So to conclude, this is our boots on the ground approach. So 2018, we developed the COG AYA Responsible Investigator Network. This is a network of AYA champions who are on the ground at our sites, and they are charged with addressing all of those barriers we showed early on in the slide set at the local site level. We want these champions to push our AYA studies through the IRB locally, advocate them, connect medical and pediatric oncology, and make sure that patients are being screened and offered participation onto these AYA trials. And I think this has been a big success for getting our messaging out. So I apologize, that was a lot of information compacted into a relatively brief presentation, and looking forward to discussion. In summary, and where we're going, we're doing better. Thanks to the work of Dr. Bleier and many who have really laid the groundwork and infrastructure to develop and lead these AYA trials. AYA cure survival and cure rates is improving. That said, we have many challenges and barriers we still need to overcome, and it is essential that we focus on opening more AYA trials and enrolling more AYAs on these studies so we can make more progress more quickly. Collaborative AYA trials has led to significant improvement. We are experiencing the fruits of all of this labor currently, as you can see in S1826, some of the other studies I've shared. We need to do this and continue to do this at the national level. And equally as important, there are many opportunities at the local level to improve care and outcomes for our AYAs diagnosed with cancer. On that note, I want to thank Kayla, Nick, Elephants&Tea for the opportunity to present here. Feel free to reach out to me directly if you have questions, and I am looking forward to a robust discussion. Thanks so much.
Wow, thank you, Mike. That was excellent. Really great overview of trials and where we've come and the barriers and kind of how we're moving forward. There's some questions in the Q&A already and a few in the chat, so we'll just jump right into them. There's questions about thinking about these barriers that you were talking about. So to begin with, from a sort of institutional level, what are the factors that people are considering from the provider level when they're deciding what trials are offered at which location? And thinking about that from a community site, academic site, and to the point is from this attendee, why wouldn't all trials be available to be offered everywhere that have the materials and the ability to do so?
Yeah, it's a great question, and that's the biggest barrier we face. A lot of it comes down to finances and what are the costs associated with locally opening a trial, and what is the return on investment for opening that trial. Now, most of us on this call have joined this call and are in this together to improve outcomes for AYAs just because we believe in the mission, and we're willing to put the work in, volunteer our time, and work to enroll more patients on trials because it's the right thing to do, and that's how we make progress. At the end of the day, our sites need to make sure that it is a sustainable model, and they have a sustainable model to be able to open additional studies and trials in the future. I think if you look at some of these national trials compared to industry-sponsored trials, the financial incentives are very different, and sites really have to make tough decisions about what is feasible and what is acceptable to do in terms of how to populate their trial portfolios, knowing that they cannot open every study and they have to prioritize some over others. Great question.
And I guess I'll add to that. Have you found that there's a difference, especially from the medical oncology world, in their the finances behind these joint trials compared to a more standard adult trial?
Completely. I think many of us who come from the pediatric world, we are used to opening almost all pediatric focused trials because all pediatric cancers are rare. And if you get, a couple enrollments that year, that trial, and opening that trial is seen as a success. On the adult side, the math is very different, and they are so busy and they see so many patients, and they have opportunities to enroll a large number of patients with prostate cancer in a short period of time. And the same amount of work it takes to open and close a study, they can get, 5 times, 10 times the enrollment in the same period of time. So the incentives are very different, and the math just works out differently. And it's just the reality of where we are today.
Um, With many, if not most, AYAs receiving care in the community settings, how do we expand clinical trial access to those specific sites in the community? Even though NCTN groups have community sites, often trials are not opened at these sites, and therefore are less accessible in places where AYAs are actually receiving treatment and care. Would we expect to see higher enrollment rates for AYAs if trials were opened in more of those settings?
Yeah, that is beautifully articulated, and I don't think you would appreciate me answering yes to that question. But there have been several efforts to increase community engagement and enrollment on AYA studies, and the largest one, which I have a role in, is the NCI's Community Oncology Research Program, in which the NCI provides financial support and resources for community sites to be able to open up more trials, not just for AYAs, but for cancer patients in general. So this was started as the CCOP in the 1980s and transitioned to the NCORP 3 decades later. And this has been wildly successful. Enrollments on cancer clinical trials in the community setting and under-resourced settings have increased tremendously due to this support. That said, most community sites are not NCORP settings. They are not NCI supported, and they are very busy, and the majority of AYAs are seen in the community setting. So these are all challenges that, unless AYAs are either referred to community sites or academic sites where trials are available, it's going to be a large challenge to get these patients access to those studies.
And then there were a few comments and questions about the role of patient advocates and how are they involved from the get-go in the planning stage? How can they get involved for those who are on the call who are patient and family advocates?
Yeah, that's a incredibly important comment. We are actively increasing the participation of patient advocates in all of our studies and trying to get them involved as early as possible for everything from study design to messaging to making sure that the community is aware of these studies. So I think historically we have not done a good enough job prioritizing the role of patient advocates. We are trying to get more patient advocates, those with lived experiences, those from diverse backgrounds, included and involved in our studies at an earlier state, because we need to address those patient level barriers. If you noticed in the slides, I focused mainly on systems level, institutional level, and provider level barriers. I've not addressed, and our teams in general have not addressed many of the patient level barriers that exist to participating in studies. And this includes everything from having a young family to not being able to take off work, to distance to sites that have trials available or don't have trials available. So great point, and would love to talk more about getting more patient advocates involved in the study design and studies themselves.
And in thinking about enrollment on trials and desire to do so, have you found, or is there data about AYA's interest in treatment studies versus post-treatment studies?
Great question. I don't have any clear evidence regarding willingness to participate during active treatment versus post-treatment. I am in the camp that strongly believes that most AYAs, when offered participation and approached in a developmentally stage appropriate manner, are willing to and want to participate on studies that are reasonable, that don't take an excessive amount of time or cost. So I believe many more of the barriers are on the provider and institution side. That said, I think patients are willing to participate on treatment, during active treatment, We have a lot of studies that are focused on post-treatment survivorship as well. And what I hear continuously and constantly, which is really refreshing, is this view that patients want to give back and they want to help the next generation, this altruism. And it's really refreshing that patients acknowledge and understand that the participation in the trials may benefit them, but that's not the goal of the studies. It's really to identify how do we do better for future generations. And so many comment that, well, they're able to receive new standards of care because of the patients and the AYAs before them, and they want to give back. So I think there's opportunities across that cancer continuum to increase participation.
And you mentioned now the cost to the patients that are enrolling. And on that note, is there any evidence that the Affordable Care Act has allowed more AYAs to accrue to clinical trials?
Yeah, it's a great question. I always worry when Dr. Blyer asks questions during these sessions. He knows the data quite well that the Affordable Care Act directly led to improvements in survival shortly after the implementation of the ACA and the dependent care expansion, which increased the ability for AYAs to stay on their parents' insurance up to the age of 26. I don't think we have direct evidence that the ACA led to an increase in AYA enrollment in trials. However, I will say it is very clear that insurance is one of those barriers and opportunities to increase enrollment. We clearly know that patients who have insurance, who are able to access sites that have trials, they have more opportunities to participate and enroll. So I personally believe that the ACA likely led to a higher participation and the increased ability of AYs to participate on studies. I don't think we have the hard evidence yet to be able to publish that, but I can't imagine it did not, as more AYAs have access to care.
And in thinking about providers and their education and knowledge of trials, what kind of outreach or education is being done to help improve knowledge about the existence of open trials and the purpose of them for additional physicians who might not be in those big academic centers who have access to all of these trials?
Great question, and that's still a challenge that we haven't quite figured out. So I think we've done a good job at developing the AYA RI networks, the Responsible Investigator Network, and sharing knowledge about clinical trials and how to overcome enrollment barriers. We've done that well within our network. However, we do not know who we're not reaching. And oftentimes I feel like we're preaching to the choir a little bit of the folks who are joining our sessions, who are joining our RI network, already are invested in the AYA population. So the question is, how do we reach more folks? Folks who clearly see AYAs, it may not be their primary patient population, but they want to help out, but they just don't have the time to join these calls or the knowledge or awareness of these calls. We are trying here as part of AYA Power to increase awareness at the trainee level. So make sure that more trainees are aware of the needs of AYAs, with clinical trials being a key part of kind of the gaps in care and the opportunities. That said, we need to do a better job. And some of that is probably partnering with governing bodies. So continuing to work with the NCI, working with the NCCN, working also with the Commission on Cancer and other governing bodies where there is more education, knowledge sharing, working with ASCO. And I say these organizations because we've reached out to them in the past and they've shown a willingness and an interest in helping the AYA population. But we have a lot more work to do, which is clear.
And then we have a question specifically to bug you. Has Texas and UT MD Anderson been able to increase AYA enrollment based on all the work that you've been doing?
Yes, and I'm really proud of that. And I'll give an example. And most of it's not because of the work I'm doing, it's because of the work that colleagues are doing locally here. The example I'll use is looking at our AYAs with leukemia, specifically at MD Anderson. So they have done a wonderful job lowering the age of eligibility of many, many adult-led trials. The same can be said with our sarcoma populations. These are studies that historically were only open on the adult side, and now these studies are being open to much younger patients, the full AYA age spectrum. And some of these studies are going, all the way down to the pediatric population. So what that means is that local champions work, right? So why did we develop the AYA network? Because clearly, if you have champions embedded in our sites, that does lead to increased screening, and that does lead to increased opening of AYA studies and prioritization. We can have all of the studies available at the national level and have a huge portfolio, but if sites are not opening them up locally, if they don't have processes to screen patients, to offer patients participation, it's not going to make a difference. So it just takes champions, it takes hard work, it takes time. Oftentimes, providers are not recognized for this time. It's because they believe it's the right thing to do, and we're hoping to do a better job of recognizing the efforts of these individuals, because it's making a meaningful difference, as shown by the S1826 study, the ANHL 1931 study, and so forth.
And then we've talked a lot about barriers and enrollment and all that, but also now thinking about the data itself coming out of these trials, knowing that the relative rate of incidence of AYA diagnoses, are the AYA trials being directly compared to all cancer trials the same way?
I'm not sure I fully understand the question. I think we are doing a better job opening up trials to AYAs. I think we have the same high standard for AYA trials as we do for other cancer clinical trials, of identifying, what are the requirements to clearly state that this approach, whether it's treatment-based, whether it's supportive care-based, is the best approach. We have struggled to develop data commons where we can compare outcomes across AYA diagnoses. And there's some work going on with Sam Volchenbaum and his team at the University of Chicago to try to have more of a data repository, so we can assess toxicity across trials. We can assess quality of life outcomes across trials and survival outcomes. We've really struggled with that, and we're hoping that with all of these AYA studies, we'll be able to actually look across diseases and not just within the context of one AYA study looking at cancer and quality of life outcomes.
I don't know if this is the intention of the posted question, but I wonder if part of it has to do with trying to compare historically to prior trials and then the data that we have now from maybe either AYA focused trials or trials that are lowering the age range, and how to kind of standardize that data or look at it across age groups in terms of our outcomes information going forward, to be able to understand, are we doing a better job for this age population?
Yeah, so great question. We're doing a better job based on survival data for many cancer diagnoses, not all. If you look at some of the sarcomas, CNS tumors, other populations, AML, we've had minimal improvements. I think the challenge that we have extrapolating data from older adult studies is that AYA outcomes are rarely reported. The AYA population, there's rarely a sub-analysis of that population. They're buried within the older adult population, which is a much larger group in terms of numbers. We published recently looking at adverse events in the AYA population on published studies that include a significant number of AYAs, and you can't tell because the AYAs their data is just incorporated with older adults. So we actually have no idea whether on these studies AYAs are experiencing more toxicity, less toxicity, if those toxicities differ. So it's difficult to compare outcomes within these studies if they're not mandated to report the AYA outcomes within these studies. Not sure if I'm completely answering the question. A little bit more of a stream of consciousness of sharing kind of some of the challenges that we still have and where we need to go.
And then another question just came in about the timing of these trials and getting them up and running. So if there's a national trial that's well fitting for a patient that it's not being offered, how long does it normally take for a review board or institution to review, select, and offer a new trial?
Great question. Depends on where you are, depends on institutional requirements. I will say there are many institutions who have a mechanism called just-in-time studies where they're able to expedite time from study submission to approval to opening to try to catch some of those patients. who have presented and need to enroll and start treatment soon. Those are not done frequently because it takes up a lot of institutional resources. Everyone sort of drops what they're doing and focuses on this just-in-time study to get it open in a short period of time. So it's probably not feasible to do this on a larger scale, although some centers have been able to do this successfully and done this across trials. It's, most of us, I'm at a large institution, opening studies, it just takes time. And having these studies utilize a centralized IRB is helpful. Having these be national studies, it definitely decreases the local review because there's a dependence on some of these national review bodies. That said, the reality is it still takes time to open these studies and make sure they're available to patients. There is a lead time that's needed.
Excellent. Well, I don't see any other questions coming in.
It felt like rapid fire, Scott. I hope the answers were somewhat intelligible.
Definitely. I guess we can pause it for a second, see if there's any other questions.
Just don't let Dr. Blyer ask any more questions. If you can, I don't know, freeze his chat, that would be helpful. But again, anyone who wants to talk more about this, you can reach out directly. I'm obviously very passionate about this topic. I will say that we've talked a lot about barriers and challenges. We're in like a golden age of AYA cancer clinical trials. I think if you were to ask many on the call 2 decades ago, how would this look and where would we be today? Some of the achievements that we've had recently with the Hodgkin trial, people would sign on the dotted line and say, great, we're finally doing these trials together. So it's a great time. It's a great opportunity. We're expanding the supportive care, late effects, and cancer care delivery portfolios. We need to keep pushing. We need to build on that momentum and not be complacent and say, we're doing pretty well, let's slow down. There are so many more gaps that we need to address. And thank you, Archie, for the comment. I expected there to be some humor in one of those comments. Maybe we'll pass it over to Kayla to round us out.
Yes, amazing. Mike, thank you so much, truly for being a part, one, of Power just in general, but for always lending your expertise to these sessions. I think that your transparency and what you may consider as incoherent responses is what is truly so special about when you have the chance and when we're able to kind of pick your brain and be a part of that. So thank you as always for being a part of this. Scott, thank you for helping facilitate such a wonderful discussion. Everyone on the call, thank you for being here. I have a few things just to wrap up. I did drop our survey link into the chat there. We always ask for feedback about our sessions for a reason. We truly value it. We want to know what's working, areas we're missing, what future topics we should be considering as we continue to grow this and offer more. I need to multitask. I'm going to drop the link for registration for our next session, which will be the last one of season 2. This session will be on May 6th at 12 p.m. Eastern. It's going to be a really special session. We're going to be talking about the One Herd initiative, which is part of Elephants&Tea, that we designed a research study to really look at disparities within young adults and the care that they receive. So we will have Lauren Gazal and Nick Galarakis presenting on One Herd, and then we will have a panel of survivors that contributed their stories to the initiative, sharing about the actual biases that they experienced in the ways that that kind of presented for them. So we're really excited about that session and are looking forward to the discussion around that and the ways that we can learn. So thank you all so much for being here. I hope that you have a good kind of start to your spring season, and we will see you next month. Thanks, everyone.
Bye, everyone.